Yeah, so my interest in GI and in obesity medicine came first, and then and I've always been sort of interested in innovative ways to treat both disorders of gut-brain interaction like IBS and obesity, and I've always sort of thought that we should do more to incorporate mind-body therapies into the treatment for both of these conditions. And then several years ago, I started learning more about psychedelics and particularly kind of the clinical trials that were coming out and are coming out, looking at psychedelics for trauma and for depression and for anxiety and kind of just the whole gamut of conditions that they're being shown to be effective for. And also reading kind of like the qualitative accounts of people's experiences on psychedelics and how it sort of helped people feel more connected with their body, kind of work through traumas or other things that were impacting them that they didn't even necessarily realize were impacting them, but were manifesting at the level of the body. And I started to get really interested thinking about the patients that I treat, and how many of them have a history of trauma and struggle with kind of some of these same issues. And that's what really prompted my interest in applying psychedelic assisted therapy to IBS, which was the first indication that we're exploring, but certainly interested in other disorders of gut-brain interaction in the future. And also, as you mentioned, I'm also boarded in obesity medicine, and I think that would be another potential avenue to explore later in the future as well. So psilocybin is the active ingredient in quote unquote like magic mushrooms or shrooms, they're colloquially referred to as. And psilocybin has been used also in many of the recent studies have been focused on depression, but also some emerging evidence with anxiety disorders, eating disorders, alcohol use disorder, and others. And so essentially, what we're looking at is using that same compound, psilocybin, but in this case, we're using in kind of like synthetic form to make sure that we can give people consistent doses, rather than giving them like raw mushrooms. And we give people 2 doses of relatively like mid to high dose psilocybin. So essentially it would be equivalent to about 3 to 3.5 grams of dried mushrooms, which is like a decent dose. Most people will have a psychedelic experience, meaning kind of alterations in their cognition, in their emotions, things from their past coming up, changes in sensation. And those dosing days are about 6 to 8 hours long. So people are kind of quote unquote tripping for quite a while. And the actual therapy on that day is relatively open-ended. It's just about supporting what's ever coming up for the patient. And then the real like meat of the intervention, in my opinion, is not just the psychedelic experience itself, but is all the therapy that patients have before, after that first session, before the second session, and after the second session to help them integrate it. So it's really a big dose of therapy, and we think that the psychedelic component really enhances the therapy that's happening. And that's the intervention. And so the outcomes that we're looking at are obviously changes in abdominal pain, changes in defecation habits that are, kind of at the core of what defines IBS, but also collecting a lot of other really intriguing kind of preliminary data, including fMRI or functional magnetic resonance imaging before and afterwards to see if there's any changes in kind of the pain processing areas of the brain. We're also having people wear smartwatches throughout the study so we can look at heart rate variability, which is a measure of kind of like a surrogate measure of how the parasympathetic nervous system is activated versus the sympathetic nervous system, and seems to be some indication that that can be off in IBS, and other disorders of gut-brain interaction. So looking at that and then collecting a lot of qualitative data about people's experiences, how they make sense of it, to help us kind of understand the intervention and also maybe refine it for future iterations. That's a hard question to answer succinctly, but I would say broadly, we know that patients with adverse childhood experiences, which are called ACEs, which include things like physical abuse, financial insecurity, sexual abuse, which is common in patients with IBS, and other types of kind of adverse experiences early in life. It seems to cause sort of it's referred to as toxic stress often, but it causes sort of long-term changes in how the brain responds to stimuli later in life. So, I think psychoanalysts and psychiatrists and therapists have recognized this for a long time, that the way that patients' early life experiences are received impacts kind of their relationships with other people later in life, right? The templating is set early on of like whether people are generally helpful and trustworthy, and whether you can help them, whether you can be helped by them and and trust them. Um, so we've kind of like seen this empirically for a long time, and I think science is now kind of catching up with like what has been known by therapists for a long time, in terms of actually being able to quantify like what experiences at what developmental time points are kind of the most damaging. Um, in terms of like how trauma can be somatically encoded, I think this concept was maybe one that was a little bit more woo-woo, for lack of a better term, less accepted by kind of mainstream Western medicine for a long time, in terms of people who have been traumatized being more likely to experience chronic pain syndromes. Um, so I think we still don't really know like mechanistically how exactly this is happening. What exactly is it about experiencing adverse childhood events early on in life, or really trauma at any kind of point in life, that changes the way that the body responds to pain? But I think more and more data is coming out daily, and there definitely seems to be some signal here that experiencing pain can sort of predispose to experiencing trauma can predispose to like a chronic pain syndrome like GI or others developing. And again, kind of trying to bring together the therapeutic approach and what's been known by psychotherapists, particularly people who are very patient facing for a long time, with, the kind of Western MD gastroenterology lens, is sometimes a little bit challenging, but there does seem to be something to the idea that helping people move through that pain, whether it is by fully experiencing the trauma, but having like a corrective emotional environment with a therapist that helps kind of scaffold healing around it, or whether it's through things like breath work that can put patients kind of back connected to their body. There's probably a lot of ways that we can help people accomplish this, but there does seem to be something to kind of trauma or experiences being stored in the body in the form of chronic pain, that a mind-body approach, and particularly potentially psychedelics, can help some people move through. Yeah, we're a long way away from it, I think, influencing like traditional Western medical practice, probably with kind of the recent refusal of the FDA to approve MDMA therapy and wanting kind of more trials before they approve MDMA. And that the MDMA for PTSD is like so much further along than something like psilocybin for IBS. So to be honest, like that kind of widespread use of psilocybin among people just being able to go to their doctor and access this therapy, that is probably, years away. Um, but we're finishing enrollment for our study in the next several months. We have pretty good and interesting preliminary data, and we're hoping to take it to the next level and kind of continue developing this drug for this indication. And I think around the world, the picture is a little bit different than it is in the US. So I think these therapies are already easier to access in places like Europe and Australia, among obviously others, Jamaica, some other places in South America. And so I think patients who are experiencing refractory IBS in conjunction with their therapists and their psychotherapist, who I think, everyone should have, but certainly people who have, this kind of traumatic background, definitely, and their physicians, to make sure that they are a good candidate for this kind of therapy with no cardiac issues, uncontrolled hypertension, things like that. I think that accessing it sooner than in the year's time frame is probably more likely to be possible.